Welcome to our Cancer Prevention and Control seminar series. We are so privileged to, from all the way up north, CSU, welcome Dr. Currin-McCulloch here. She's an assistant professor in the School of Social Work at CSU, and is the lab director of the Serious End of Life Narratives Research Lab, which I think we're going to be hearing a little bit more about. She got her master's of social work from the University of Georgia and her PhD from the University of Texas, Austin. But fortunately, we've drawn her up here to the Rocky Mountains. Her work is informed by 2 decades of oncology and palliative care social work experience across a multitude of healthcare settings, and encompasses adolescent, AYA, adult population, as well as the 4-legged, non-human companions for folks, exploring the human lived experience of serious cancer, survivorship, and palliative care. So, and I just want to shout out to Jen. She was recently selected as a in the highly competitive Sojourner Scholars Leadership Program in what will be the program's final cohort. So, without further ado, thank you.
Jen, humble person. So thank you, Stacey. Appreciate the introduction. Nice to see you there, Linda. So yeah, all the way from Severance, Colorado, you imported me today. I'm really excited to share with you about some of the work that I do. I won't bore you with all of it, but I'll highlight 2 main parts of what I do: my medical aid and dying work, and then work with young adults that have advanced cancer in a photo voice project. So I all of this. I also love doing family and group work, and so you'll see that as well. Showing up here is my caregiver research, and my photo voice works with young adults in a group setting. When I was working, I've always worked at essential hospitals or Catholic hospitals, and really feel part of my work is to be there to support anyone that walks through the door, as I'm sure many of you have that same kind of feeling in the work that you do. So I've been honored to work with folks that even prenatal oncology, when I worked at Ronald McDonald House, very centenarian. So it's been a wild ride, almost 30 years now since I graduated. So I really love working with young adults. When I was in the hospital, I met so many cool people who had these amazing lives that they were living as young adults, whether students or artists or athletes. And then, as you all know, life really becomes interrupted in young adulthood going through cancer. And a lot of folks are struggling with, who am I? Where do I fit in my family? My parents are trying to come back in. I'm not doing the things that really bring joy to my life. And so I went back to school and got my dissertation and looked at how do young adults with advanced cancer define and maintain hope in their lives. And so that work kind of really has led me to looking at existential quality of life, also looking at disenfranchised grief and loss experiences. And that's how I get in the human animal bond work and who is significant for somebody in terms of One Health approach to care. So it kind of summarizes my work. I'll talk with you a little bit about what kind of theories or philosophies guide me. And like I said, we'll talk about medical aid work and through the lenses to my photo voice project. And hopefully have time for plenty of questions and discussion at the end if you all would like to do that. So I'm really drawn to a story. I think as a social worker, I eat up every bit of life narrative that folks are willing to share with me. So I'm really drawn into narrative medicine and helping support folks and really thinking about, now that we have a life-limiting illness, how do we re-author our lives in a way that we feel this new change and people are trying to impose a story on us? How do we fit in and what is meaningful in that story? I love William Breitbart. You all follow meaning-centered psychotherapy. He started it a long time ago with folks that have advanced cancers. And so looking at how do you find hope, meaning, purpose, some of these existential quality of life things, a sense of belonging, particularly in young adulthood. It's such a rare type of cancer or time to have cancer in your life, disenfranchised experience, right? So how do you find meaning and purpose and connection? I did my dissertation work on grounded theory, so I've really been drawn to looking at social and psychological patterns of behavior, which lead people to do certain types of things. And then now I'm really digging embodied phenomenology. And so my medical aid and dying study will be talking about phenomenology. Are any of you all total geeks and get into phenomenology? Okay, so you'll get a good geek lunch today. I'm glad you got food to keep you awake on that. But so I'm going to start out with some work. Stacey and Ryan and I are talking about what would be interesting for folks to learn about. So we talked about kind of splitting medical aid and dying and work with young adults with cancer. My medical aid and dying work does have some work with folks that also have neurological illnesses. So I want to share a little bit about that and the juxtaposition of some of the tensions. If you all are working in palliative care, you may come across some folks with neurological or maybe comorbidities as well. So you may see a little bit of neurological illnesses pop up or cardiac illnesses, but really it's that sense of end of life and this decision to pursue medical aid and dying. We talking with Stacey about how challenging it is to recruit folks who are they themselves pursuing a medical assisted death or folks who are their caregivers. And so we were fortunate I had 7 people who were about to die, and 2 of them I got to interview twice, and then I had 32 caregivers. Some were in the meeting with the folks right before their death, and some we followed up longitudinally learning about their experiences. So it can be a death that happened 3 days ago and a death that happened 5 years ago. We really wanted to see how grief looked across the spectrum. Also, medications have changed, so trying to see really what that can look like and how that can impact one's narrative. So a broad array of stories. So phenomenology, you look at what your life world is. It's kind of, you think about all of your senses when you wake up in the morning. It's what you see, you're smelling. Also, it's really important in phenomenology as you're looking at space and place and time, which is not really something we look at in a lot of other ways that we approach research. And time, when you are in a body that is time limited, is very important. Also, when it's a issue that relates to illegal of a law in some state or not in another state, also some very beliefs for folks. It's really important to think about what space and place means and who's around you. So I'll talk about those aspects as well. So basically it is phenomenology looks at a person in the world and what are these different facets of the world that impact the phenomenon of what someone's going through. So this is the phenomenon of folks who are approaching a medically assisted death. So starting with the body life world, as you can imagine, if you were somebody that I was interviewing that 48 hours from now knew was going to be the day they drank the drink or swallowed the poison, have all kinds of fun names that people call it. So within 48 hours, they knew their life would be ending. It's really important to think about the body. And the body is really the sole part of this life world that we have found really intertwines with everything. If they were somebody that was feeling better and they weren't in a terminal condition or terminal state, then maybe the body would not be as important, but it really weaves throughout every aspect. So as you can imagine, folks, heavy symptom burdens when you're working with folks that have a terminal condition. So significant pain that interferes with their life, challenges in moving limbs, speaking, swallowing, brain tumors, so cognitive capacity or ability to make some of those decisions or discussions is really present for folks in every moment of their life. And so a lot of conversation was about, I'm in a body that there's a lot of things I could still do in this world, but my body does not allow me to do it. They were just ready to go out and do things. They did not want their life to end. They are not somebody that were like, this is something that I would consider. They want to live as long as they can and as beautifully as they can. So this is a social worker who was in her 90s that said, if my body was healthy, I could think of lots of things I might still be interested in doing, but not with this body. It just wants to go to sleep. Normally, a normal body takes care of itself. When you're alive, you're not thinking about your body and whether you should drink water or not. what then becomes the mainstay of your day? What kind of life is that when you're thinking about, can I drink water or not drink water? That's not the kind of life for me. This is a very professional woman that was, ahead of the field in the work that she was doing. And she had legs that were just, her edema was so bad, they would be puddles when she would go down to assisted living. And she said, people are like, what the hell is that coming out of your legs? Was a quote she was using. So really the sense of who she was and living constantly and having things that we just do and take for granted, being able to drink and absorb any liquids was now ruling her life. Also a lot of folks that, had to wait every moment wondering, will my tumor grow? Will it take away my opportunity to make the decisions about things I want to do in my life? I'll talk a little bit about body surveillance in a minute. This is kind of what's going on in the body life world. And within that life world, we have our emotions. We also have our sort of spiritual world within our body life world. And so there, as you can imagine, a wide array of feelings like we all feel in every day. And a lot of these feelings are very similar to folks that we would say have an unplanned or a natural death, maybe compared to a hospice death would be what I might call another type of death, but they would be all very similar. And I would say 95% of the folks that we interviewed were on hospice as well. And so anxiety was common, one's own grief and grief as a caregiver, so pre-loss individual grief and not the family. A lot of frustration with one's body, frustration not being able to do what one typically could do, but also a whole lot of frustration with medical systems, barriers, laws, lack of access to resources, in particular, like in our state, sometimes we only have one pharmacist who can do the compounding for the medications. And so if you are living all the way in Glenwood Springs and you needed somebody for the medication and it's a bad snowstorm and 70 is closed, what are you gonna do? You're gonna have to wait even longer. On the flip side, there is a lot of beautiful peace and hope. I think as a social worker, I like to think that there's always hope in every aspect of life, maybe hope for less pain, hope to be with a family member, hope that maybe I won't be in pain for a long time. In this group, there was this sense of, I call it like a celebratory expression. A lot of family members described what it was like for their family member at the last of life, maybe in the last 48 hours. We saw pictures, so a lot of folks were having parties and celebrations. One young woman made herself up in the Day of the Dead and took on, she's a very spiritual person, so brought a lot of spiritual practices that she had. But we saw folks that this, when you have go to a wedding or a graduation and you have this sense of glow on your face, and we were talking about what is this? This is really an unusual expression to have on your face when you are actively dying in many of these cases. So we talked about maybe it's a sense of an existential assurance, right? That you have this relief, that maybe your relief is coming, but also being able maybe to live out your last wish, that you can choose medical aid in dying and maybe not have to have an extended amount of pain or have an experience maybe that you've seen someone else have. So I asked a woman who was, I think, 85 at the time, living in an assisted living facility that did not allow her to use the medication in the facility. So she needed to go somewhere else to use the medication. This is pretty common for most assisted living facilities, especially in our area. We have a lot of facilities that are have policies, whether it's based on a faith-based organization or just like, you don't want this kind of death to happen here. So very few of our sample were able, I think 2 out of the 39 folks that we interviewed were able to use an assisted living facility. Not all were assisted living capable, mind you, during that time period in their life. So she had to go to leave, and so she was going to go stay with her daughter. And I asked everyone, like, what are you thinking about? What's on your mind? What are your feelings? She's like, or describe it for me. What are your last days going? She said, oh, it's going to be a picnic. I'm like, I'm sure my face, I saw it on Zoom, was like, what? Picnic? I've never heard of a death being described as a picnic before. So that's interesting. That's really cool. Tell me a little more about it. She's like, I'm going to feel like I'm actually going home. It's going to be a party for me. And so she was like, I'm going to have the chocolate I love. I'm going to have my daughter that I love around me. And this is something that I feel important to me. And really, as a person that was a knitter and sewer who, had some issues where she no longer had feeling in her hands, so couldn't do the things that brought joy to her life. So for her, that was a sense of the celebration of being able to have her final wish. So thinking about the tensions, a lot of the tension and frustration is around uncertainty of illness. I think you all are really familiar with how that can be really plaguing in somebody's every moment for the person and the family, right? And so because of that, we have this beautiful description of somebody saying, you're really on this razor's edge of time. It's so thin, you never know when you're gonna cross over the time where you cannot no longer have control of your body. And for folks that have chosen a medically assisted death, it's even more important because they still need to be able to self-ingest. And so self-ingest doesn't mean you have to be able to pick the cup up, but you just have to be able to still suck through the straw. There are some interesting things that are happening, like you have to be able to show intention of pushing the flange for a feeding tube or rectal tube, sorry, those are eating. Y'all are probably good with that though. There are even some things for now folks that can work with eye movement where people can be trained to move a plunger because of their eye movement. But still you need to be able to have cognitive ability to say, yes, I'm aware that when I take this medication that my life will end. There's no going back once I take this medication. And so for folks, there is a constant state of surveillance. Many states have a 15-day waiting period between the requests. So it's that extended period of time that folks are waiting to have that. So they're already anxious, right? And what's gonna happen with my body? Am I gonna make it to the second doctor's appointment? And people don't. So there's that. I think in folks that have neurological illnesses, can I still swallow if I am and I don't have a feeding tube of some kind? Can I still use my hands enough to show that I'm making the intention to push it? And so a lot of folks were worried that this would happen. This quote I have here is from a young woman that had breast cancer with a large brain metastasis. A very spiritual person. She said it's kind of like being caught in a catch-22 because it's like ideally there'd be enough cognitive ability to go, okay, I'm tracking my body. I can see that's going down and changing. I can see this would be the optimal time to take this drug. It kind of like scares me a lot. I mean, that would be the ideal way to deal with it, in my opinion, to take the medications. But can I make it work the way the law is written? So this sense of tension of like, when's the moment that it's going to be too much? Also, it was common for folks to surveil what was going on with their family and their support systems in their life. I'm sure y'all have met people in your life that live for momentous occasions when their body or their CT scan is like completely white with masses. But a lot of folks were waiting, those especially with children, were waiting for a time when they felt like their children or their partners were ready. Also were ready that they had the social supports should they let people know that they were choosing the medically assisted death, that they had support systems in place that would not be there to further stigmatize them or further disenfranchise their experiences and grief. So as you can imagine, that values are very important and one's beliefs, whether that be spiritual, religious, or one's own philosophy that they hold, and whether they choose a medically assisted death in general or not. A lot of folks that we talked to, these were kind of the key things that they resonated from their narratives or from the caregivers that described who they were as a person and their life story and why they made this decision. So control and agency was large, as you can imagine, wanting to be able to say, I have control over my body and the amount of pain that I experience. I have the control over the way that I die. I have control over the way that I celebrate me in every moment to the last moment. Relational autonomy. There was a lot of tension of me versus them, and do I put myself before others, or do I go ahead and make this decision? So some folks had to wait till they had a caregiver around, until their caregiver was ready. Some matters around finance to make sure that family members were taken care of. So folks were really having a lot of intention about setting up to make sure everyone had what they needed before their final day. Identity preservation, a lot of folks, we talk about death with dignity, as how the movement started. And so what does dignity look like for someone? And a lot of folks, it's wanting to go out of the world the way that they were seen in the world. So I saw lots of parties, celebration photos, and what people chose to wear for their final, what they wanted to be buried in, and, make sure the pearls are just right, and the dress is just perfect. So they got to really make sure they had their say, which was very important. So here is another social worker. Interestingly, most of the folks we talked to had, at least the folks that were choosing medically assisted death for themselves, were physicians, social workers, highly educated engineers. So they all had high degrees, high access to resources, had a lot of money, a lot of education. This is not an illness, and I'll share it with you in a second. You have to have a lot of resources, not an illness, sorry. It's not an end of life process that you can do without a lot of resources. So the social worker said, I was really losing my identity, which has been the hardest part of my whole disease process. It's difficult to lose physical capacity and functioning. It's difficult to go from somebody who's really, athletic, active, and healthy to be someone who sees each part of the functioning sort of just deteriorating. So again, it's a sense of control. I want to keep who I am the way I am. And thinking about social world, who we are, phenomenology, we look at a lot of who we are in the world and how we engage with the world. So we're never, as we all know, our whole lives are co-constructed. We can't just walk out in the world and it's just us. Like the wind comes, the birds fly by, a car passes and cuts us off. We're always in the world with others, right? And so the social life world we looked at is how are we in relationship with our roles and what we typically do and our sense of purpose in the world, and also our relationships and interactions with others. So for most of these folks, it was a sense of, I'm done. Everything that meant life, which meant for me a sense of meaning and purpose, that's no longer here. Others, they were concerned that others can't rely on them anymore. So it came up a lot with parents, as you can imagine, and partners. I want to be the mom that I want to be. I don't want to be a mom that can't do these things that my child needs for me. I mentioned a moment ago about social stigma for the for the patient and the caregiver bereaved. A lot of folks, Stacey, we're talking about this is large in terms of folks aren't telling others that this is the death that they've chosen. Family members are not telling them, and so it's really awkward for some folks that do know. And so their grief process looks like, I just talked to them on the phone an hour ago and they were fine and then they died. This doesn't make any sense. So there's some unresolved grief and understanding what's going on there, and complicated grief for folks. Also some complicated grief if folks have been going along and like, I'm not gonna need it for a while, and folks like, my health has changed dramatically, I'm gonna do it tomorrow. And so folks who thought they would have a chance to have this planned ceremony are not having a planned ceremony. And so that's probably the only other time that I've seen this complicated grief process. So yes, personalized creative ritual. There was a therapist who was dying of cancer, liver and brain mets, and she told her family that you can be present with both love and sadness at the same time. And the family were very, it was around Halloween, and had a great sense of humor. And so they brought in a death cart with like a skeleton and skull and crossbones on the beverage that she was gonna drink. And so everyone like brought their personality to it. It's really hard when you're doing these interviews and you're seeing these pictures and these stories and you're like, how do I respond to that? And I'm just kidding. So it's really being present in the moment and following these cues and these interviews from folks. But there were so many beautiful, beautiful stories. I'm someone who's really drawn to music, and so folks would talk about the music that was playing, and so then as I was coding, I would put music on, just put it on repeat so I could kind of be in that moment with them and be in there as much as I could, right? I'm not them, but in that life world and the experience. So that's kind of like phenomenology. You're trying to get in it as much as you can. A lot of the caregivers talked about their grief experiences and compared them to other types of death that they've had in their life. And in the moment, for many, it was challenging because maybe they'd been the one that had mixed the medication They're like, oh, I'm the one that mixed it and gave them that medication. So there was kind of a little bit of a whirlwind of grief in that, which was different, I think, than other deaths, as you can imagine. A lot of folks compared the death to voluntary stopping eating and drinking, other family members in states where it was not legal, and talked about kind of the preference for not seeing somebody go through that extended period of time and what's going on in their body and their mind and seeing that suffering. And then compared to some deaths that had been through hospice, maybe it was before it was illegal in a state or not legal in a state, and talked about some unbearable pain that they witnessed. So they did a lot of comparisons. There was a lot of meaning making done in the process of what this meant to this person, how it was able to help them fulfill that wish, how it's helped them to be able to have that control and maintain their identity. So this is somebody talking about, so I know I'm done, there's nothing else I can do, sense of being done, right? There's nothing else that I can do, it'll be useful for anybody, including myself. I have a friend who says she wants to stay alive no matter what, and I thought, why? Why do you want to stay alive no matter what? It's not my style. So that was her sense of, she wanted to be, she's done, there's nothing else that she could do. So real quickly, these are some of the legal things and the space and place, which matters where your body is positioned and the resources that you have. I think of this kind of like as privilege or resources that and barriers that can come up. So you obviously have to meet the terminal criteria and have 2 physicians in our state to approve you. You have to have a caregiver. There's really no way to do this without having a caregiver. You have to live outside of a sort of like a federal facility, so no hospital, no nursing home, some assisted livings, like you said. You have to have financial means not covered by insurance. The prescriptions aren't, so it can range between $600 to $1,000. It has been $10,000 when it first came out, so it's a little better. California does cover it through Medi-Cal, through their Medicaid program, but many states don't. We talked about being able to self-ingest. And then you have to live in a metropolitan area where you have access to physicians, you have to have access to pharmacists, or you have to have somebody that, like I said, some caregiver that can make the calls. And it's a lot of legwork and a lot of barriers that can come up. Okay. Yes.
This is amazing, deep, wonderful work. What words were people using commonly to describe this for them? Like, we have several words that have evolved over time, like even, medical aid in dying. And I think at some point, maybe you said medication assisted, but it's also striking me that caregivers and to some extent the patient are needing to take on medical tasks or perhaps nursing tasks, but maybe or maybe not the hospice team is there or not. And I'm also just struck by there's clearly lots of preparation happening, and yet perhaps not a preparation of for care partners. What can they be saying to the people who want to know what happened?
Oh, how can we prepare care partners to have those conversations, or maybe
Yeah,
dialogue?
I just said a lot of different reflections. I think the one piece would be like, I wonder if there was a common aspect of what language they called it for them. I'm planning to take these medicines, or like, what would?
Oh, it's as wide as the people are, right? Variety. Some folks are gonna take myself out, drink the poison, drink the drink, end my life, the final day. I mean, it's a variety of terms, and it based just on kind of who they were and how they present in the world. Some folks had just said it like it is, and some folks described it in a little more fluffy, flowery ways. Just kind of, I think, who's around them and just their spirit.
And then did you find that bereaved caregivers were then often mirroring that same language, or were they using different language?
Yeah, if we got to meet them before and after, they would hold that same language together. They took a lot of cues from the person as somebody's having control over their experience. I think it was definitely modeling of behavior, and I think folks did tend to listen to what folks were using as cues. But there is, I think, if anything take home before I move into the photograph land, is that there's so much education we can do around the emotional aspects of this and the disenfranchised aspects, but how to prepare people. Yes, a lot of people think it's going to be totally easy and it's going to be like, I'll get the prescription, I can go home. It does give relief to know you have it, but there's so many barriers to have to go through, and time takes longer than it's going to take, and finding the support can take longer, and it doesn't happen in 5 minutes. Once you take the medication, for many it is within 10 or 15 minutes. They are no longer conscious of what's going on around them. But for some folks, it can take longer for the body, and depending on maybe their absorption processes and things like that. So it's preparing them for that, and also helping to connect them to resources where they can find, as a bereaved person, somebody that's also been through the same thing, because they are not finding that in regular hospice or regular grief groups. They're getting a lot of social stigma. Stacey, is there anything you want to add?
Oh, just real quick to bounce off Currin said, so do they say suicide at all, or
Never.
no? That's
Never.
just
No, yeah,
not
definitely not.
the
Yeah. Some people, family members, did compare it to a family member that had maybe a terminal condition, that had no access, or a long time ago who had died by suicide, and so compared that experience and grief. But no one chose to describe that other family member for themselves in that process.
What do you take from that?
What I take from that, I take from that a lot of people wanted to live as long as they could live, and in almost every situation, everyone's like, I would be here if it wasn't for my body, and there's so much I still have left to do. Yeah, so many people, I've still got these tattoos I need to get, and I want to go and do these trips. So none of these folks wanted their life to end. They wanted their suffering not to be here, but they did not want to stop living. They didn't want to lose who they were as well. Cece, is there anything that you found that I'm missing?
No, I just wanted to applaud like your work, and just to put it in context, like there's so little out there about this and what people are experiencing, and your work is groundbreaking in that sense. And I think it's further challenged by some of the federal restrictions around. There's a federal law that's basically states that you can't do anything that's going to help people or convince people or facilitate ending someone's life, and so this falls under that, and so it's really I think restrained a lot of research on how do we help caregivers.
Absolutely.
How was this funded?
So yes, the Colorado State paid for my pilot to get everything going, and then I have through my research lab, Compassion and Choices, and ACA MAID, which is the Academy of Clinicians American. I get the A's all backwards, but it's physicians and nurses who work in this field, small donations. So pretty much I'm paying all of the interviews that I do, give them all their incentives. So it pays for my student to help me code. So yeah, very little, very, thank you, Stacey. That's very important to mention. Perfect, okay. I'm gonna shift. We'll have some end of life stuff, but it's gonna be in the words, in the narratives and images of young adults with advanced cancer. So this is the intervention that I created with a peer of mine, Danielle Peterson, another oncology social worker, which is the 8-week meeting-centered psychotherapy group intervention that's virtual for young adults that have cancer. This will be my Sojourn Scholars Project, will be to train mental health providers around the country how to lead this in their area. So I've got money to pay for whoever wants to join me. And in the end, each local group will do a photo voice exhibit, whether online or in person, like a photography exhibit, basically. Then I'm going to do a national campaign in Palliative Care Month, November 2025, and really just get the word out there that young adult cancer is so different than other types of cancer and how it can be there to support. So the young adults call this Through the Lens, Life Beyond Young Adult Cancer, not survivorship beyond, but like, how am I going to live my life outside of cancer? And so these are images and narratives, have permission from the young adults to share. They were very eager to share. So this is a young woman that has had a blood cancer for over a decade. That said she has a hard time going to doctor's appointments in the hospital because people don't ask her how she's doing, besides what symptoms is she having. And so she can borrow your stethoscope and put her stethoscope right here. And said, I want you to see these third eye things that I'm going through. So some of these existential things that are meaningful to her. Think about another young adult that, speaking of hospital things, but had all of her, you know, those gross orangey yellow pill bottles that we have, right, for medications, had them all lined up and stacked up like that's all you saw in the picture, and then you saw two eyes sticking out. And she turned all the labels that said these could kill you, these could kill you, and all the hazards on the outside, and she said, this is my curative treatment. And then here I am trying to look out of all these poisons. So I would say I've led groups for almost 30 years, and this is the most impactful, quickly bonding. We talked about miscarriages and infertility in the first 20 minutes, like things that can take months or even years for folks to talk about in community. So I had to like literally buckle myself up each time I joined for the first time. Another young woman with a blood cancer said, voices, chemotherapy enhanced my hearing. It also enhanced the opinions of others. So what you should be doing, what you shouldn't be doing, you know, still lives at home, can't have a life. This is a young mom with breast cancer, not the horse, sorry. It's a young mom with breast cancer sharing her story. Her father died of cancer at the same time she was going through treatment. And she says, sometimes I feel fierce, strong, bold, and brave. Sometimes I feel like blending in. And so it's that, right, that cancer survivor, like this warrior thing. I'm so strong, I beat my body. And then sometimes as a young adult, you just want to be a young adult. You want to be a mom. You want to be the job that you have. You want to have that life you don't want to be. You want to be, you know, somebody that's standing out as different. So how can we help folks find what for them helps them feel strong and courageous, what gives them a sense of purpose? This is what a lot of this intervention is helping folks to think about who were they before they got sick? What part of that life is still meaningful? Or how can they take the narrative that they have from their illness and go out and impact change because of their illness? This one really hit me as this is a chaplain who's had 2 cancers in her life. One is a child and one is a young adult. So the caption in the cemetery is "Last Woman Standing." I'm aware of the ghosts that walk with me. I'm aware of the darkness I try to carry off on my back. So she talked a lot about survivorship guilt. And as a young adult, you know, lose a lot of your peers because we don't have as great a treatment for this age group yet. And so what does survivorship look like for them? Losing a lot of friends. This person joined group every night from their bed, and the first woman joined from a hospital bed. And so being hooked up, not being hooked up, she was on heavy duty narcotics. And so she would be in group sometimes with her eyes closed, but they would jump back in. But that's the benefit of having a virtual group and being really intentional when you set up your group community environment. Come as you are, be who you are. So, tattoos obviously are a big important thing in young adulthood. So we had pretty much every group, we have a night where tattoos come up as a topic. And speaking of identity and things like that. So again, to the strength. And just as the phoenix rose from the ashes, she too will rise, returning from the flames, clothed in nothing but her strength, more beautiful than ever before. Sorry, thinking about this one. A young woman that came to group every week with her NG2 then, hooked up to the vacuum suctioning. And as you know, working in this field for a long time, you know the writing on the wall. You know who, you know, she's going in, you know, has a lot going on and having organs shifted and moved and taken out. And I'm thinking she's not going to be here in 2 or 3 weeks. And so holding that in the group, when she may know that, but maybe she doesn't know that because there's a new experimental surgery. And this is a big time musician, right? Who's played with some of the biggest people. And I'm sitting there seeing her as she's looking with the tube and super, super thin, and this is what she wanted, this is her goal, is to get my music and get her swag back. In my heart, I'm like, I don't know that swag is coming, so how am I helping reframe also in this process? What hope is for folks? How can I help them achieve a goal that seems similar to that? So I think those are some of the photos I have. Super powerful work. If you are drawn to the young adult world, if you want to lead a group, I can help you learn how to do that. But just some of the folks that sponsored my work. Open for thoughts, questions.
Incredible. I mean, that was, and we have some ideas about exhibits. We'll talk to you
Okay,
later about. I'm wondering, can you kind of walk us through what like the framework of the group is? Like, how many meetings, how long, like what does that structure look like?
Yes, sorry, yeah, perfect, great question. So there are 8 weeks, kind of typical manualized group kind of thing. Think about 8 weeks, an hour and a half. Folks zoom in from wherever they are. I've led 4 and done accessibility and feasibility and gotten to publish on that. So then we created the manual. So we kind of provide the structure for folks that want to learn how to do it. There are topics for every night that work off of meeting-centered psychotherapy. And so it's the first one is who am I? You don't give them any prompts about what to bring. You tell them to wear, who might see your photo. You tell them, like, if you're in a hospital setting, maybe wear earbuds or put it on mute or close your camera when, if nurse staff comes in to support you. Or if you have kids wandering around, we'll do sometimes see folks, and just that privacy is a little different when you're doing a Zoom-based intervention or whatever platform you use. So first one starts as who I am, who am I? So think about, like, who are you? What makes you who you are? So folks don't tend to come talking about their cancer in that one. The second night is the only night we have dedicated specifically to cancer. And so folks will bring whatever picture, whatever they have going on, talk about their illness that night. Some folks never say what type they have cancer, even that night, or what type of cancer, over the course of that whole 8 weeks. So this is pretty cool. Usually it's like, I had this treatment this day, and this is my surgery, and here are my scars, but it was more general, like, we're young adults in this together, and this is what my social world looks like now, and how can I make it look better? And then we go into what gives life meaning, what's your sense of purpose, who holds you up when you're having a hard time. There's a lot of nature, a lot of cats and dogs come into play. On that night, we have one focused on hope and future, and then one that's on legacy. And I have to say that's the hardest night. I have to prep for it. I also have to prep for the night where we talk about what are you proud of? Because a lot of folks don't like to talk about what we're proud of. And so we think about, is it a relationship you have, especially if you're a young adult, maybe in your school and you had to leave school for a while, that which you're really proud of and that you hold on to, your family hold on to, you don't have that. So restructuring what it is that you have done that's powerful, which I think is meaningful for a lot of folks. And then so legacy is hard because a lot of folks might not have a legacy past 2 months from now, a week from now. So what does a legacy look like to you? So we prepare them for what that it's going to be a harder night. It's going to be a challenging night. Pictures are really hard for folks to think about. So we really have a lot of time. That's the second to last night. The last one is living in uncertainty and how do you hold hope in uncertainty. So we try and end on that positive note, but we always, of course, always laugh, we cry, we dance, we show videos. Like, there's a young adult one time that had been so many times in the hospital, she saved all of her bracelets and put them all the way up her arm. She's super skinny, so she could put them all the way up her arm. And then she had done a TikTok where she was dressed up like, some famous person in a sassy, sparkly dress, and then was doing like her bracelets like this, other things going on in life outside of their cancer treatment. Were more important for folks to focus on, and building that community where they could stay in touch afterwards.
What is your age range for young adults? Because I find that varies with different organizations and.
Yeah, it's really tricky. 18 to 39 is what I have, but a large group Cactus Cancer Society goes to 4 to 5. And so it's really tricky thinking about that and where we're going. We're gonna write a paper on that 39 to 45, 40 to 45 and what that means to folks. One day I'll get there. But yeah, great question.
Do you have any guidance for working with providers who are resistant to the idea of medical aid in dying? Doctors that, have patients that are interested in that and trust their doctor, but the doctor wants to, refer to someone else or just won't even entertain the discussion.
Yeah. I find it's hard if somebody is against it to change their mind. I think it's based on values and who we are. I think it's based on oaths that people take and how strong they feel about the oaths as well. I think for me, my advice would be to share narratives of things that are available and experiences in the words of people and how it does offer a sense of relief, a sense of hope for some. For me, I can't speak for me, but I would share narratives of people who've been there. I think some folks warm up to it, but it's really tricky. Mm-hmm. Thank you all for coming and listening, being here. If you have questions, I'm up the road if you need me.
Thank you so much.